design, we thought that we'd need a standardised protocol, and we had 2 radiologists with double reporting. And in terms of histology, we try to get the best histological information we can. Now, obviously, radical prostatectomy, getting the prostate itself, is the ideal situation, but that would be completely unethical. So we used what we thought was the next best thing, which is grid-directed transperineal template mapping biopsy. And then we validated that against the proportion of men that went on to radical prostatectomy. So we took 400 men over a 2-year period and enrolled them in this prospective trial. So our selection criteria that we used was, obviously they had an abnormal PSA or DRE. They were over 40. They had a life expectancy greater than 10 years and no previous MRI or biopsy. And obviously they couldn't be contraindicated to MRI. And we, as always, got ethics approval for our study. In terms of the multi-parametric MRI, these were performed at 2 centres, and what we actually attempted was to have a look at a range of, or at least 2 different MRIs. One was a 1.5 Tesla, what we'd call a low-end magnet, and the other was a 3T, what we'd call high-end magnet. So we basically randomised or alternated the men's between both of these centres. And then each study on the 1.5T and on the 3T was interpreted by 2 radiologists that you have before you, independently and blindly. We used the PIRAD system. We actually used the PIRADS 1 system. I'm not going to go into too much detail because Ron's really described the PIRADS 2 system, and it's a very similar system. It gives a likelihood of cancer. And what we did is, as Ron has said, you look at the anatomical imaging, which is the T2 weighted imaging, the contrast enhanced imaging, which is the perfusion and the diffusion. We gave each of those a PIRAD score. Then we gave an overall PIRAD score. So then what we did was took the average of those 2 PIRAD scores between Ron and myself, between the 2 radiologists, and we classified and we looked at various areas or lesions within the prostate, and we took the highest PIRAD score which we'd call the index lesion, to signify that study's PIRAD score. So if there was a lesion that had a PIRADS 4 and a lesion that had a PIRADS 2, obviously we took the highest one. Then we averaged them, and we defined a study as negative, that is unlikely to have cancer if it had a PIRAD score of 1 or 2, and we defined it as positive if it was greater than 2. So we really have a binary outcome, a negative MR or a positive MRI, and that helps with the analysis. So this is our cohort, basically a median age of 63 years, PSA of 5.2, about 45% had an abnormal digital rectal examination, about a quarter had a first-degree relative with prostate cancer. As we were aiming for an even split on the MRs, which we got, and as I'll show you in a second, the percent of positive MRIs, that is the combined PIRAD score of greater than 2, is about 77%. Remember, the population we're looking at is just not the general population. It's a basically selected population of people with abnormal findings, either PSA or DRE. So just for the radiologists among us, and even the informed urologist, the specifications of the 1.5T magnet, so it was a low-end magnet. It had a maximum gradient strength of 30 millitesla, slew rate of 100 milliteslas per meter per millisecond, and it was 8 channels, so it's really a basic level 1.5T magnet. The 3T magnet, on the other hand, had 32 channels with a maximum gradient strength of 80, which is good by any measure, and a 200 millitesla per meter per millisecond slew rate. We performed a standardised protocol as outlined by the European Society of Urological Radiology. that include 3 planes high-resolution T2 weighted images, the diffusion that Ron's shown you so well there, and we did not use an endorectal call, even at 1.5 T. Okay, so this is just the comparison between the 1.5 T and the 3 T, and because we were standardizing the protocols, we got pretty similar spatial resolution, maybe slightly better on the 3 T. Okay, so here's a question for you. One row is the 3 T and one row is the 1.5 T. Now, I all know you're expert radiologists and probably reported quite a few MRs. Does anyone want to have a guess? Who thinks the 3 T is the top one? Who thinks the 3 T is the bottom one? Okay. So just with regard to MRI, really, even if you have a low field strength, you can make up for that with various things by doing more averages and et cetera, et cetera. So even on a 1.5 T without an endorectal call, you can get very good image quality. You just have to work that little bit harder. And your patients have to be in the scanner that little bit longer. Okay, so the diffusion weighted protocol, this is where the 1.5 T struggles a little bit. So when we looked at the B values, we could get up to about 800. It was hard to get higher than 800 on the 1.5 T because of that, the lower gradient strengths, where the 3 T could go up to 1,500. Because we were standardizing the protocols, the pixel size was roughly the same. The field of view was slightly larger on the 1.5 T. And the slice thickness, we couldn't get it down to 3, but we got it to 4. So who thinks the 1.5 T's on the right, left? I'm a radiologist, I'm not sure which way I'm going. Anyway, that's the 1.5 T and that's the 3 T. I think you could see the 3 T's a bit better on the diffusion. Okay, and the contrast enhanced protocol, we tried to get as good a temporal resolution as we can by fixing spatial resolution. So with the higher gradients, the 3T did a little bit better, 8 seconds, the 1.5T 11 seconds, but everything else was pretty standardized. And this is the 1.5T and this is the 3T. This is a typical anterior tumour. I can't have a lecture without giving an anterior tumour because that's just what we do when we give lectures on prostate. So you can see here the anatomical images showing that erased charcoal sign. This did have a washout curve, and this is just a typical example of one of the tumours that we diagnosed. So what would we do? We'd examine the MRI, we'd find the areas of abnormality and we'd score them and use this topographic map to locate them, and I did, and I think Ron did too. Number 1 would be what you thought was the highest PIRADS lesion, but it didn't really matter. You could go through and then you, as we said, this MRI would be scored as the highest lesion of the number of lesions that you've got. Okay, so with regard to the biopsy, the transperineal template mapping biopsy, we took, Phil and Phil Brenner took a median of 30 cores from an 18 template biopsy. And on top of that, if they felt they had the MR and there was a small lesion that was probably cancer, they'd do an additional 2 targeted biopsies. And as Ron said, there's a couple of ways of doing that. So one of the ways that they did it was an MR truss fusion biopsy, but also they used a cognitive technique because they are very good at reading the MRs as well and in their brain locating that and matching it up when they're doing the biopsy. Okay, so the histology was processed and reported in the standard fashion using the International Society of Uropathology, 1 uropathologist. So for the core biopsies, they looked at the length of cancer in each core and the Gleason grade by taking the primary and secondary. And then for the radical prostatectomy specimen, there was a standardized method of looking at that with 3mm sections. Then they looked through all the specimens and located, just as we did with the MR, the foci of tumour. They graded the tumour. They looked at the tumour stage and the margins. And then they, as well, had a very similar topographic map to us and labelled those lesions, including the index lesion on this. And then, as I'll show you later, they were correlated. Okay, so clinically significant cancer or significant cancer. So prostate cancer can be graded as low, moderate, and high, and there are various definitions of that. And they can be strict and they can be less strict and they can have volume criteria. And in the literature, there are many different ways that people chose to define their risk category. We define clinically significant cancer as the moderate to high, but we chose a definition of, which is reasonably standard, of having at least 5% of Gleason 7 or above. Or in terms of volume, 15% of cores positive or any particular core having greater than 7 millimetres. But there's many ways to do this. Okay, so then we looked at anatomical concordance. So any MRI positive regions or regions of interest were correlated, as I showed you, with the pathology. But then we also looked at the pathology and found areas of cancer that weren't identified on the MR. So we sort of did a 360, and we did that for both the biopsy specimens and the radical prostatectomy specimens. So what did we find? Well, for various reasons, only 344 patients completed the trial, and there are many reasons for those. 266 of them had a positive MRI, and as I said before, that's about 77%. But remember, this is a high-ish risk population. 63% were diagnosed with cancer, that's low grade, intermediate grade or high grade. And then 143 were diagnosed with significant cancer by the definition I just gave you, which is 41%, which is quite high. So if we look at having a positive multiparametric MRI, which I defined as not being 1 or 2 on the average measure between me and Ron, we found that we had a sensitivity of 96%, which is quite good, and a moderate specificity. And we had a negative predictive value over those 344 patients of about 93%. So when we said it was negative, that is when the combined score had a PIRAT score of 1 or 2, in 93% of the time, that would be a true negative. The positive predictive value was moderate at 50. Oh, sorry. Okay, so this is a table that just shows you how things can vary according to definition on those on the sensitivity, specificity, and some of the other parameters there. So if you just take prostate cancer biopsy, that's Gleason 6, that's low, intermediate, and high. It changes things somewhat. But when you start to look at significant prostate cancer, and we looked at several different criteria, there wasn't really that much difference when you looked at those definitions that I gave you. So really just a couple of percentage points different there. So this table is busy. And a little confusing. I've tried to make it less confusing, but what this is saying is out of all of our patients and all of our PIRAD scores, if a patient had PIRAD, so out of all the patients we looked at, 2.6% of patients had a PIRAD score and no prostate cancer. A better way of looking at this, actually, I've done the percentages, is of all the people that had PIRAD score of 1, no one had intermediate or high risk, and 65% had no cancer and 35% had low risk cancer, if you understand that. And say in PIRADS 5, out of all the patients that were given PIRADS 5, none of them had low risk or no prostate cancer. 50% or 55% had intermediate and 46% had high. PIRADS 3, as Ron has said to you, is sort of the bane of our existence. I actually think it's improved a lot with the new PIRAD system. The old PIRAD system sometimes forced you into giving a 3, even though we suspected that it was inflammatory because we were reporting by strict criteria. So we're talking about ways of improving that, and I think PIRADS 2, would you say? Yeah, it has. Okay, so what about our radiologists? Well, there was quite good consensus between both of us. The kappa score was about 0.63, which is substantial agreement. And if you have a look at this bottom chart here, this was sort of calculated halfway through our results. If you look at RAD1 and RAD2, they're very, very similar on all these scores, even with a number of patients up around 130. So there's pretty good agreement. Just looking at some of the results. So when we had a look at the univariate analysis, we saw that PSA, digital rectal examination, age, and the PIRAD score were strongly associated with significant prostate cancer with a very low P-score, right? But interestingly, we found that MRI and family history were not. MRI strength. So the 1.5T and 3T didn't matter if you're on the 1.5 and 3T, it didn't really influence your diagnosis of cancer. Even when we did the multivariate analysis, we found very similar results. The PIRAD score, PSA, DRE, and age were all independent predictors, but again, magnet strength and family history were not. So we took magnet strength and family history out of our model. Now, if we look at the area under the receiver operator curves, you can see here, now this is sensitivity and 1 minus specificity, and a perfect test would follow these axes here and be like an L-shaped or a reversed L-shape there. If you take a multivariate model but take out PIRADs, you get, so that really is PSA, DRE, and age, you get this curve here, which has an area under the curve of about 0.73. If we add PIRADs to the model, you can see that the model does pretty well, much better, and your area under the curve increases to about 0.87. So doing the MRI and assessing it with the PIRAD score in the way we were doing does add significant value in predicting significant prostate cancer. We also had a look at stratifying the patients according to risk. So what we did is took the higher risk patients, and when we say higher risk, we mean a PSA greater than 10 or an abnormal DRE out of the population of men that we were looking at, and there happened to be 159 of those men. And if we do that and apply our PIRAD scale, we then achieve a negative predictive value of 100%. A positive predictive value of 64%, but our specificity is quite low. But in that population, we could have saved up to 11% of biopsies, and we didn't miss any significant cancers. So that's a higher risk group. In the lower risk group, so that's the other cohort of men that had a normal DRE and a PSA less than 10, that was about 185 of the men, we achieved a somewhat less negative predictive value, still good, 90%, positive predictive value of about 37, okay? But because there are more negative men in this cohort because they're lower risk, the number of men that we saved having a biopsy with that negative predictive value is higher. 27% of those men would have saved a biopsy. And we only missed or seriously delayed diagnosis of significant prostate cancer in 3% of that cohort. Just looking at the cancers that we missed on MRI, there were 6 significant cancers, but all of them were intermediate grade, 3+3 or 3+4. So we didn't miss any high-grade cancers. Okay, so what about the anatomical concordance analysis? So this is looking at the biopsies. So if we looked at the biopsies, the positive biopsies, positive on MR, if we looked at the men that had a positive MRI, that's a PIRAD score of greater than 2. When you looked at me and Ron looking at the MRI, you had 265 men. Okay, so then we took those 265 men and looked at the positive regions of interest within the MR and compared them to the regions of interest within the biopsies. In this case, we're looking at the saturation biopsies. And we found that there was a 97% concordance of significant cancer between the MRI and the biopsies. We found that only 3% of those men that had a positive biopsy but did not have that area outlined on the MR. So it's a very, very small percentage, 3%. Further to that, we found about 11% of men had significant prostate cancer with concordance. That is, we've found the index lesion on the MR, but they also had another focus of significant cancer, but we didn't outline it on the MRI. That probably wouldn't have changed management, or maybe it would in the focal case, but I won't go into that. In no case did the separate significant lesion have a higher tumour grade than the index lesion that we described on the MRI. So overall, the concordance is quite good. So in the radical prostatectomy analysis, much the same. 109 men had positive MRs who went on to radical prostatectomy. Again, it was a 97% concordance, meaning if we outlined a lesion on the MR, 97% of the time the lesion matched or was very close to the pathological lesion. And again, only 3% of the men had a mismatch. In radical prostatectomy analysis, it was 13 rather than 11% of men had concordance, but another clinically significant lesion. So overall, we felt that MRI was providing good anatomical concordance. So just discussing some of our results. So in our study, mpMRI MRI did detect clinically significant prostate cancer with a high sensitivity and somewhat limited specificity. So routine pre-biopsy multiparametric MRI could improve the detection of clinically significant cancer and avoid unnecessary biopsies in 23% of cases. That's our entire population. But if I just showed you in the lower risk case, it was 27%. Using the best available pathology or histology to us in this prospective trial, we found that MRI only missed diagnosis of significant prostate cancer in a very low percentage of people. So overall, MR added significant value to the diagnosis of clinically significant prostate cancer. The determined anatomical mismatch, as I just showed you with that concordant analysis between the region of interest and the pathology, was quite low. And therefore, our study supports the view that targeted biopsies may one day, or probably will, replace these saturation biopsies and these somewhat blind biopsies that are occurring in lots of institutions today. So our results are pretty comparable to previous studies. The specificity and positive predictive value rates vary quite widely from 20 to 60%, but a lot of that is determined by the population you're looking at and the reference tests that you've used. Although it's been suggested that 3T should possibly yield better results than 1.5T, in our study, both magnets did approximately the same at predicting. There was no significant difference. And PIRADS 3, at least in the PIRADS 1 model, getting a bit confusing, but the old PIRADS model did cause some problems, and I think that's improved in the new PIRADS system. So what were the limitations of our study? Well, those template matched biopsies, the transperineal biopsies, were used as a reference test, and although they are a good reference test, they are not a perfect reference test. And no follow-up at the moment has been done on the men that had a negative transperineal biopsy, and there may have been cancer there that possibly we missed that might express itself later. So overall, we concluded that multiparametric MRI, even at 1.5T, has the potential to improve the selection of men for biopsy and hence save biopsies for several men, decrease unnecessary biopsies and over-detection of low-risk prostate cancer while maintaining a low rate of missed significant prostate cancer. using transperineal biopsy as a reference standard, we thought that this our study at least was considered optimal for assessing the performance of multiparametric MRI. But obviously, as with anything, additional validation studies will be required if we want to move to that step of actually replacing the saturation biopsies with targeted biopsies. So that was it.
Okay, thanks. Thanks for inviting me. And I'm apparently the only informed urologist in the group, so I was really happy that. Who acknowledged me as an informed? Oh, you do. You acknowledged me as. Okay, so the aim of this was to more put it in perspective of how we're actually using it. We've been at the forefront of sort of doing a lot of work in MRI in the prostate, and so I'll just go through some of the things that we think it has a role in, or in fact I use it all the time. I'm a big believer in MRI of the prostate. Not a single patient that I treat now does not get an MRI of the prostate. It's just a routine, and I suppose it would be the same as knees. You wouldn't do a knee operation without an MRI of the knee. So its potential roles are, as our study showed, potentially in screening, potentially in helping us biopsy and targeting. The patient who's got a negative biopsy previously and a rising PSA, that's where it's actually approved and actually recommended in the guidelines, European guidelines and American now. But that's the only place it's actually in a guideline. I'll tell you how it aids in choosing therapy. Also, pre-op staging before surgery and radiotherapy, pre-radiotherapy planning. In patients who have active surveillance, where you've decided to monitor them, we're currently doing a trial to see if we can replace biopsies with MRI. A hell of a lot less invasive. I mean, 5 years ago, everybody was getting a yearly biopsy. People who have PSA recurrence, post-definitive therapy, again, MRI has a role in that. People who have oligometastatic disease, who have less than 5 secondaries, where there is now a belief that that treatment may have a survival impact, there's a role for there. With focal therapy, given the fact that our region of interest is actually quite accurate, and particularly if it's supplemented by saturation biopsy, focal therapy is an emerging field which could well be relevant in 15-20% of patients, and then a little bit about the future. So I'm going to run through it very quickly in the interest of time, and it's late. The consensus statement which we wrote for the Urological Society, we wrote back a couple of years ago, and that's really changed a lot since we wrote that for the British Journal. I'm not going to go through what Ron said or PSA screening, but what I will say is that if we're talking about screening, there are 2 massive studies. One's called the PLCO study, or this is the American randomized study. It did not show a benefit to screening men for prostate cancer. The European study did, but at a very high cost of overdetection. So PSA is not a great test. Then I did a publication in the British Journal of Urology showing that, well, how about we do an informed risk-adjusted thing? You depending on their PSA level, depending on their age, maybe you can sort of screen less frequently, and once you get to 75 and your PSA is 3, or 70 and your PSA is 1, then there's no risk of cancer of the prostate. So you could have a risk-adjusted thing to make it cost-effective. But even that has its limitations. And then, of course, we've got the terrible problem of prevalence of prostate cancer. So if we look at the prevalence of people who have low-risk prostate cancer, if you look at, this is a different slide, beg your pardon. So in this, we were looking at the 4-year likelihood of having prostate cancer. And if you're under PSA 1.5, you've got an incredibly low risk, but then as soon as it goes higher, it's got a higher risk. So it's a very broad sweep. So what you could do, you could say people under 1.5, you just never ever test. So what's the perfect...
Sorry, I didn't get that.
Is that Siri? Good. You don't press Siri in the middle of a lecture. The perfect screening test, of course, is where the test does not pick up cancer, does not pick up insignificant cancer, but picks up significant cancer. The problem with PSA, it picks up insignificant cancer just as much as significant cancer. So it doesn't help us because we're now over-diagnosing prostate cancer, which was never destined to cause a problem. So MRI, the major questions we have at the moment for MRI: one, can we avoid biopsying PIRAD 1 and 2 lesions? Well, you heard from our study that you'll miss 3%, you'll delay 3% if you've got a good radiologist reporting it, and I do emphasise a good radiologist, because one of the big problems with this is bringing this in, it has to have some type of level of competence, and otherwise you're going to get an incredibly different results. But you will save up to 30 to 40% of patients having unnecessary biopsies. Just think of the 75-year-old guy who walks in, the GP's done a ridiculous PSA, it's up to 6 or 7, the urologist is stuck. He doesn't really want to biopsy this guy, so he gets an MRI. The MRI shows negative. You've got a 97% likelihood that you haven't got any cancer. You save a 75-year-old guy possible journey to intensive care for gram-negative septicemia. It stacks up quite well. Can we do targeted biopsies and omit the template random biopsies? In our series, we would have missed about 3 to 5% of cases had we have done targeted biopsies. And so, again, if you just want to diagnose the cancer, that's all you need to do. If you believe in focal therapy and you're going to miss 5%, it's not the way to go. So that data is useful. And can you reliably use MRI and a template biopsy to then select patients for focal therapy? These are the big questions in urology at the moment, because focal therapy is on the emerge. We don't want to unnecessarily biopsy people, and we don't want to do so many causa biopsies. So, first of all, answering the first question, our study showed, that's Thompson and al., showed a 93% negative predictive value, Picorni up in Queensland 96%, and Numeo over in Korea 93, 96. It's been validated. Can we avoid the templates? Well, you can look down the numbers again. It's somewhere between 3 and 10%, depending on whether it's cognitive and what the endpoints are. But ultimately, you can pretty well avoid doing saturation biopsies in everybody. What about can we reliably use MRI and template biopsies to select it? Well, 4% have a separate lesion of 0.1 in MRI negative lobe, and so if you according to a radical prostatectomy specimen, that's our study again. No, I'm sorry, that was a different study using the same cohort. But the thing we've learned, so you will miss a very small number of people doing a focal treatment. And what we've learned is that when you start looking at radical prostatectomies in these solo lesions, they have a halo sign around them. And that halo sign is you have about up to 9 millimetres of cancer around what you see on the MRI. So if you widen the field by 9 millimetres, you get 100% knockout of the cancer. If you do what I originally did was 5 millimetres, you start getting rim recurrences. Since I've been doing 9 millimetre treatments, you get a complete treatment. So that has implications as to which energy source you use, because lasers don't go wide enough. And for example, so that there's all sorts of implications there. So the rationale, therefore, for using MRI and screening, less biopsies, less over-detection, age localisation. You don't get the biopsy artefact by doing it after the biopsy. There's early detection in high-risk patients. We used to tell people after a biopsy, don't worry, we'll just keep watching the PSA, and if it keeps going up, we'll do another lot. And then with the second time, don't worry, if it keeps going up, we'll do another lot. And the percentage kept going down. But with this, I've done a separate study which shows that if you do an MRI and a template biopsy, the chance of a recurrence down the track, which we haven't published on yet, is less than 5% over almost 4-year follow-up. So that combination is an incredibly powerful combination. It's very reassuring in older patients. It's more accurate for actually grading because you hit the middle of the cancer, the part with the lowest ADC value. As a prognostic aid, it's fantastic. You can really see whether you've got a low ADC, which means that that patient is not suitable for active surveillance, or a high ADC. So the ADC becomes important. And the interval change in high-risk patients may in fact end up being the most important thing that we see. You're watching these patients, say a person's got a BRCA2 gene, where if you wait till the PSA gets to 4, 50% are incurable. So therefore, if we put the MRI earlier in the paradigm and do that on an annual basis, maybe we'll pick them up early enough to cure these people. So they're all the questions. That's a little bit of repetition. This is going through the study that you just heard, because we all keep promoting this study. In fact, we're doing a review for a book coming out at the moment to decide what the official statement's going to be on MRI by the Urological Society, by the Prostate Cancer Foundation, and there's only 6 studies out of 350 which were screened, and ours is one of them, that were actually of high enough quality to actually be used. This is all exactly what was shown to you extremely well by Daniel. Okay, so this is the way I think it's going to pan out. Guy comes in, you've got a raised PSA, slightly elevated PSA, you do an MRI. MRI is negative, you follow him up. The MRI's got mild suspicion. In the old system, a PIRAD3, you follow him up. Because don't forget, the MRI, the low level of suspicion MRI with a low PSA in that particular subgroup, it's less than 20% chance of something. High level of suspicion, you biopsy him. If the PSA is less than 10, same thing, but the mild suspicion goes into biopsy, and over 10, everybody gets an MRI just to help you know where to biopsy. And I can't believe how fast this has changed. So I was one of the first people to be doing this type of thing, and then all of a sudden everybody does an MRI before a biopsy, and that happened within 2 years. Multiparametric, we're repeating what we're saying, biopsies. The current technique of biopsies is not adequate, and I'll go into that. Is MRI-guided biopsy better, which is the best MRI-guided technique? Do all patients need an MRI-guided biopsy? Should we still biopsy the rest of the prostate? The questions that we need to answer. This is the problem, that if you've got a transrectal biopsy and you've got a cancer here, you might miss it. You might hit an insignificant cancer, or you might hit the insignificant part of a significant cancer. So all those are problems. There was a systematic review by Carolyn Moore over in England, and she works with Professor Mark Emberton at the University College Hospital. She's very, very bright. She's one of the leading lights in this area, and she did a great review, and that basically showed that MR-targeted biopsy identified clinically significant cancer in an equivalent number of men than standard, and it does so with fewer biopsies and fewer men with fewer diagnoses of insignificant cancer. That was the conclusion of the review of the literature. And that was the actual studies that she looked at. I'll pass that. So one thing to realise is that transperineal biopsy is better than transrectal biopsy, and I very strongly believe that because of the infection risk. And one of the things I was involved in developing, I developed this in 1996, the transperineal biopsy technique, and now it's just starting to snowball that everybody's using it, mainly because of the risk of extended beta-lactamase bacteria. And because a lot of the people the 2.1% of people who get septicemia after transrectal biopsy, if they've travelled to Asia recently, have quite a high risk of these incredibly resistant bacteria. And there's been not quite a few, but a significant number of deaths as a result of that. So anything to minimise that, such as a transperineal approach, is a good thing. So it's safer. It's better than for active surveillance selection. It's better for targeting because you've got a template. It's better for selecting focal therapy because you've got a template. And it's better at assessing MRI accuracy. And they're some of the 3 papers we published on all those. We did a prospective study of 409 patients of our own, Phil Brenner's and mine, where we looked at the sepsis rate, and we had 1 patient with sepsis. And interestingly enough, even though he had a fever and he came in, we never proved he had a urinary tract infection or a prostatic infection, but he got a temperature over 39, so he got down to that. I've done about over 7,000 transperineals, and I've had 1 admission to intensive care over all that time. And if you compare it to the audit of the Urological Society, it was 2.1. That was admitted on a random audit, not a prospective study, clearly underestimating it, of septicemia requiring admission to intensive care. So it's more accurate, and in fact, it is the most accurate way of, and it compares very favourably to the radical prostatectomy specimen. These are just some horror shots of the infections. You know, this is a sloughing perineum from somebody who had a transrectal. So let's go through the options of how we best do a biopsy. MR gantry, MR fusion, or cognitive biopsy. And what's right for whom, and what's the advantages and disadvantages. So MRI in gantry is transrectal, but it's only a couple of cores, and you can clean the rectum and you can drop the infection rate down. And some of the people who are good at this have claimed they've never had an infection. And Les Thompson in Queensland at the Wesley, for example, has claimed he'd never had a single infection. And he's done probably about 700-800 of them. It is the most accurate way because it's verifiable. It's the only way you can put a needle into something and then take a picture and say, I'm in the middle of it. There's a learning curve. There's unquestionably a learning curve. I'm good at learning that curve. You guys will be bad at learning that curve. You're not used to a moving prostate all over the place and trying to hit the right spot. Okay, Daniel, he's shaking his head. No, maybe he is. But there's unquestionably, it's foreign territory. It's inconvenient. It's unpleasant. It's not that pleasant to be inside an MRI machine having a thing shoved up your backside. It's transrectal, the danger of infection. Occasionally it's difficult to access in certain parts of the prostate, but it is ideal for redos because there you want to be sure that you've got the needle in the right spot. What about MR fusion, transperineal? It's less accurate. It's not verifiable. It's safer. There is a learning curve there too. Really easy for the needle to bevel off to the right or to the left, and you can't be 100% sure. And whether it's deformable or not deformable doesn't really matter. The more technology between you and getting the needle into the spot is actually not necessarily going to get you a better biopsy. It's convenient.